Time to take a coding break. Howdy, coding pros. This is your coding break reminder, your medical coding coach, as well as your medical coding instructor, Tam Talk, here to talk about all things the good, the bad, as well as the ugly as it relates to the medical coding industry. So on today's coding break, I want to talk about meat. Where's the meat? Not where's the beef, or maybe it is the beef, but where's the meat, as in the meat of the documentation. So on this coding break, I want to just talk about some of the insufficiencies as it relates to the MEAT, and that's M.E.A.T. Monitor, evaluate, assess, and treat. Again, MEAT as it relates to evaluation and management, and the documentation or the provider documentation as it relates to the evaluation and management of conditions or diagnoses. So what are some of those insufficiencies? So for M, for those of you who don't know, M is for monitor. Failing to document the signs and symptoms or disease progression or regression. Yes, we must know that the progression or the regression of a medical diagnosis. Sometimes when you're reviewing a clinical note or clinical documentation, the provider may list diagnoses but does not give you any indication on the status of that diagnosis, like whether the patient is proactively following the treatment plan or if they are non-compliant with the treatment plan. So again, the insufficient documentation of M, or the monitoring of a said diagnosis or assigned diagnosis. Our next one is E, which is evaluate. What is the insufficiency in E, or the evaluation? Again, the lack of documentation, where we don't see the lab results, whether or not the medication or prescription that was assigned or given to the patient, if it was effective, or again, if the disease is progressing or regressing, or was there a physical examination performed? Did the doctor or healthcare provider perform a clinical examination or physical examination and document those findings? So our next one is A, which is for assess. What documentation is missing from the assessment? For example, they may, again, it goes back to them not documenting the status, the severity, or stability of a condition, especially the chronic conditions such as diabetes or hypertension. They may just simply put hypertension or diabetes, but is hypertension chronic, like ongoing, or is it just elevated high blood pressure? Is it acute? The same with diabetes. Is it pre-diabetes? Does the patient have type 1, type 2? Or they are compliant with their medications? And for those of you who are new to the medical coding industry, you may not know, for example, the prescriptions that are associated with said or specific diagnosis. But for someone who may have been in the industry for a long time, they may be aware or I would say aware of certain medications that go with certain diagnoses. And I can give a personal instance where I was assigned or prescribed a medication, but the medication was for a different diagnosis, but it also could be used for my diagnosis. So when I would go to the the pharmacy to pick it up, the pharmacy techs were under the inclination that it was for the most common diagnosis that patients use prescription for. But in my mind, I'm thinking, well, my provider did not tell me I had this diagnosis. So do I have this diagnosis? Do I need to follow up with my provider to confirm whether or not I have this diagnosis? Because this was not mentioned to me during our evaluation. So it's like, so I'm doing my own research. So the next time I did see my provider, I did inquire about the reasoning for taking said medication. Again, like, am I diagnosed? Is this my diagnosis? Is this a new diagnosis? Because I was under the impression it was for this diagnosis. So at the risk of not, violating my own HIPAA. So again, that documentation is very important. Like, why are you assigning or prescribing a medication? Is it acute, or is it a chronic condition? Is it stable, unstable? What's the 411 on this diagnosis? So yeah, documentation is very, very important. And so, which brings us to our last, I would say, letter, which is T for treat. Again, if we're lacking the documentation of, was this patient referred out? Was there any medication changes? Is there therapy plans? What is it like? Okay, how are you managing? Overall, how are you managing this diagnosis? Again, simply listing out diagnosis and simply listing out medication does not provide adequate information for a coder to assign a code. Now, like someone, again, if you're a dumpster diver, and when I say dumpster diving, I mean like researcher, or if you've been in the industry for a long time, you kind of understand and kind of can relate certain treatments or prescriptions to certain diagnoses if you see them both listed. For example, you may see lisinopril. We know that is a drug for like hypertension, right? Or we may see, I'm going to say insulin. That's very generic. We know that it pertains to diabetes. So things like that, like, again, if you've been in the industry for a minute or in healthcare for a minute, and you kind of see certain things over and over again or repetitively, then you kind of know, I would say you can kind of assume that this is what this is for. But we are not doctors, right? Medical coders are not doctors. Medical coders, certified billers, healthcare information managers are not doctors. We can play doctors by looking at the documentation that the real doctors have documented, but we are not the doctors. We cannot diagnose the patient. We cannot provide treatment options or therapy plans or whatever. We're going based on what the real doctor, the real clinician, the real nurse practitioner, the real physician assistant has diagnosed the patient with, and we're basing our assessment on, again, the documentation that the healthcare provider has documented. But in the event the doctor or the healthcare clinician lacks documentation, again, we're playing doctor based on what was provided to us, right? So it is very important, and again, it's very, very important that the healthcare clinician documents appropriately. Now, with electronic medical records, EMRs, and the templates that are being implemented, sometimes a doctor or a clinician may copy and paste certain parts of that template for documentation. One, to save time, and two, pretty much to save time. And so that can be detrimental as well, because you're not really giving the status or the progression of that patient's diagnosis, their treatment plan. Like, again, are they progressing or are they regressing? So it is very important that, again, that the provider documentation is up to snuff, right? That it meets compliance. As someone with a compliance and auditing background, there are certain things that we do look for, whether they, regardless of whether they change how, like it used to be medical decision making. It used to be physical exam, history, HPI, chief complaint, all those things. Now it's M.E.A.T, M-E-A-T. We are still looking for those key things to see, that provide us with the status, the treatment, the management of those particular diagnoses. So a medical coder cannot do their job unless the doctor or the healthcare clinician do their job. And part of the healthcare provider or the clinician's job is to document appropriately, right? If they want to seek reimbursement, and we're going to, as coders or coding professionals, we're going to base or assign our diagnosis or procedural codes based on what is documented by the healthcare provider. So it is very important. And again, I cannot reiterate the importance of a healthcare provider and clinician documenting appropriately, whether that be through transcription. I hate to say handwriting. Yes, there are people who still handwrite their records, their documentation, or through electronic medical record using templates. It is very important that the documentation is up to snuff. again, because we are not we, but the healthcare providers are audited, whether that be through an internal auditor or an external auditor. But we'll talk about that at a later time. The difference between an internal and external auditors, internal is like they work for the healthcare clinicians. External is maybe a third party that comes in and randomly selects a handful of records from different providers, whatever that case may be. It could be I would say a retro audit, and based upon their findings, they provide that feedback to that healthcare entity or the leaders of that healthcare entity to show where there was potential to lose money or to gain money. But nonetheless, we're looking at the overall medical documentation by a healthcare provider. So again, I asked the question or posed the question, where's the meat? Where's the beef? But really, where is the meat? So that's all that I have for this coding break. And as always, remember to code on until the next time. Toodles.